Ladies and gentlemen, we are at the appointed time. Welcome to this afternoon's iEcho meeting, which is hosted by the GI Foundation of South Africa. The topic that we are going to cover today is the radiological and endovascular management of the complications and bleeding of portal hypertension and hepatocellular carcinoma. Mark, I'm going to hand over to you we've got three speakers, and I'm going to hand over to Mark Burnham for the first presentation.
Thank you very much, Bob. I'm just going to share my screen. So we decided on this topic because we've currently got two patients in hospital, or actually three patients in hospital who've had vascular problems and required vascular interventions, and they've all got either HCC or are in a screening program for hepatocellular carcinoma. So if we look at there's really two main bleeding issues that patients with HCC have. The one is spontaneous rupture of HCC, and the other one is bleeding varices. And we know that hepatocellular carcinoma it sometimes presents with bleeding varices, specifically if it's invaded into the portal vein and resulted in an increase in the portal pressure. And then Gershwin Human's going to talk to us about some of the vascular interventions that patients with cirrhosis and hepatocellular carcinoma sometimes require. And I've broken them down into embolisation, which can be bland, chemoembolization, TACE, and that can be done the conventional TACE or with drug-eluting bleeds, and then radioembolization. Then we've got various endoscopic ways of getting rid of varices. So I was thinking here mainly of gastric varices, but obviously with esophageal varices, there's banding. With gastric varices, there's various forms of sclerotherapy. And then there's new techniques with endoscopic ultrasound, and then TIPS or transjugular portosystemic shunts and balloon-occluded transvenous obliteration or other techniques that can be used. So the first patient I'm going to discuss is a 79-year-old lady who is a widow. She used to work in the post office. She lives alone. She's quite independent. Her children have all immigrated, and she looks after herself. She drives to the shops, and she's fairly active. Not a smoker, no alcohol use. She does have porphyria, and she was seen by our liver clinic in that regard many years ago. She's also diabetic on oral therapy. She has dyslipidemia and hypercholesterolemia, is on a statin for that. And what happened is she basically collapsed at home. Her neighbor checked on her from time to time and called an ambulance. On arrival at another hospital, she was hypertensive with a hemoglobin of 5.5, and she responded very nicely to fluid resuscitation. There was no evidence of encephalopathy. She was not jaundiced, but her abdomen was distended, not tender. She had shifting dullness and ascites, and there was no obvious palpable hepatomegaly or splenomegaly. So I rated her performance status as 2. The Child-Pugh score B8, so a good B. MALT score 10. Her HB now, this was not when she presented, is 9.9. White's count normal. Platelet count 194. Her urea is elevated, and she has an element of hepatorenal syndrome. Total bilirubin 23, and no other apart from the diabetes, no real risk factors for cirrhosis or hepatocellular carcinoma. Ammonia has not been elevated. So I'm just going to show you the scans that were done. Initially, there was sorry, let me just go back. There was a CT scan and a MRI scan that were done. So this was when she presented with the bleeding. You can see the fluid around the liver. The liver is shrunken and it's a little bit irregular. And initially, I actually sort of found it a little bit hard to see, there's this bit of liver that extends inferiorly, and right on the end of it is the tumor. You can see it there. And that's what ruptured and was bleeding. The alpha fetoprotein is not elevated. So just some other views of this. So this is on the axial view. And that's the tumor next to the kidney. Initially, when I first looked at the axial scan, I thought it looked like another kidney, but once you can follow it up, you can see clearly that that's a bit of liver tissue and an abnormal tumor that had ruptured. So our working diagnosis is a ruptured hepatocellular carcinoma. I mean, an adenoma, I suppose, is a possibility. I think it's less likely. She's got cirrhosis, and she's got a reason for having an hepatocellular carcinoma. So, and on the arterial phase, which I'm not going to show you, it was not particularly hypervascular. So Gershwa embolized that tumor, and she's actually done very well. She's walking around the hospital, and once we've got her social circumstances sorted out, we're planning to discharge her. And I suppose the question is, what is her prognosis, and how should we treat her from here? So transarterial embolization for HCC was first described in Japan in 1977, and as I said, there's conventional TACE, which used lipidol and doxyrubitin and gelatin sponges, and then there's been development with drug-eluting beads, and we sort of alternated between the two. We started using drug-eluting beads quite a lot, and Gershwa can speak to it, but we've gone back to conventional TACE. The evidence there is quite difficult to assess because there's a lack of standard technique. There's very heterogeneous groups of patients, and there's different indications for TACE. But I think the biggest thing that's happened over the last probably 20 years or so is that I think we've got a better understanding of who benefits from TACE, and we usually use it for either as a bridge to surgery or transplant, or in patients with intermediate stage disease. So I'm going to go on to speak specifically about ruptured HCC. The reported incidence of spontaneous rupture of HCC is decreasing, but in Asia and Africa, the incidence is as high as 20%. In the West, the incidence that is now reported is in the region of 2.3 to 6%, and I think that's just because patients are in screening programs and are being picked up earlier. So I think it's not that unusual presentation in Africa. Ruptured HCC is currently classified as T4 in the TNM staging protocol, and it's generally associated with a poor prognosis. Risk factors for rupture include increased size of tumor, cirrhosis, hypertension, portal vein invasion, and it is more common with increasing age. Rupture is theoretically associated with tumor dissemination, but having said that, in most series, peritoneal metastases are quite rare. So in areas where embolization is not possible, and before embolization was an option, the traditional surgical approach was basically packing and ligation of the hepatic artery, but that's associated with quite a high morbidity. But that could potentially be a life-saving option if there were no other facilities available. Endovascular treatment used usually with bland embolization, and like I said, that's become the mainstay of treatment for patients with bleeding with a ruptured HCC. Surgical resection has been associated with poor outcomes, and I think it's now performed selectively. And if you look in the literature, I think the group of patients, it's done in two groups of patients. It's done in very stable patients with peripheral or pedunculated tumors. And then it's occasionally done as a staged hepatectomy after initial embolization once the patient is better. I was looking at whether transplantation is an option after ruptured HCC, and what I could find on that is that most patients with ruptured HCCs fall outside the Milan criteria, but it's not an absolute contraindication in most transplant programs. So I identified a few studies that looked at it. This was a study from South Korea that was published in 2021 in the Journal of Gastrointestinal Surgery. And they identified 7,600 patients with HCC that underwent hepatectomy in South Korea over a 16-year period. There were 115 patients that had had a hepatectomy after a rupture, and 38 of those had an upfront resection, 51 had TACE prior to surgery. And they matched those patients with 85 patients who had a rupture, they took 85 of those patients and they paired them with patients who had very similar characteristics with regards to size, alpha-fetoprotein, and other tumor characteristics to patients with unruptured HCC. And they tried to match them and compare the effect that rupture has. And you can see the survival at 120 months in the unruptured group was above 50%, in the ruptured group just below 50%. So it definitely does have a detrimental effect on survival. This was a systemic review that was published in 2018, looking at management outcomes and prognostic factors of ruptured HCC. And you can see here, if you look at all comers, the 5-year survival after ruptures is only 17%, and the disease-free survival is only about 10%. And they looked at different approaches in the different groups of patients. So, like I said, you can see any approach, the overall 5-year survival was 17%. If patients were managed conservatively, and I suppose there was a selection bias there, the 5-year survival was 0, and the 1-year survival is only 1%. With embolization, the 1-year survival is 37%. And then patients who had hepatectomies did better. But once again, I suspect there's a selection bias there, as the patients who had hepatectomy were probably a better group of patients from a liver function point of view and a general fitness point of view. So I think in conclusion, what we can say, spontaneous rupture of a HCC is a poor prognostic factor. In addition, it often occurs in patients with bigger tumors, with worse liver function and elderly patients. Embolic therapy is very effective, and it's a nice way of controlling the bleeding. And it's a good first-line option in most patients. And I think it's the definitive treatment that most patients are going to receive. I think surgical resection, while not absolutely contraindicated, is associated with worse outcomes in similar patients who have not ruptured. So it's not an absolute contraindication, but I think you have to think long and hard before you consider that sort of treatment in these patients. I'm not sure if there's any questions at this stage.
I'll just, Mark, just with with regard to your patient, it's really very interesting because she has a normal alpha-fetoprotein. She's got quite well-preserved liver function. You mentioned that she's a B and scored 8. And she's got this very interesting pedunculated tumor.
Yeah.
So I'm just going to ask you the question, is it really an HCC, or has she got a ruptured hepatic adenoma? Is she in the right age category, and isn't she a candidate for laparoscopic mini resection?
So that's what I was thinking. It is a very easy liver resection. One has to factor in her age, but I think the nice thing is we can do another TACE even, and then consider see how she goes and consider resecting her. And it could be an adenoma. I mean, we haven't completely ruled that out, and it certainly doesn't have definitive imaging characteristics for an HCC. So I don't know if Mark Sonoropoulos here, but so me and Mark had a chat about this. So I don't know much about porphyria, but he was saying to me that there's been some discussion about whether porphyria in itself is a risk factor for hepatocellular carcinoma. Mark?
Yeah. Hi, Mark. Hi, Jake. You can hear me?
Yeah.
Okay. Yeah. I mean, The issues around this patient that makes it interesting is, of course, the fact that she's got a possible HCC, the adenoma question aside. And, why does she have an HCC, or why would she have underlying sort of chronic liver disease? I mean, she has been a bit overweight, and she had lost weight. And so she certainly fits a metabolic profile for possible steatosis. But the thing that struck me in her history was that she gives a very good account of having been screened and having had at least one episode of acute porphyria in the 80s, in fact. And both her and her sister were screened and were told that they have variegate porphyria, which kind of makes sense, and VP makes sense because of the familial link between her and her sister. So the risk of porphyrias and HCC sort of is something that arose for the first time in the late 90s, and it was first raised by the French, that there was a link between the acute hepatic porphyrias, which, just by way of reminder, is variegate porphyria, acute intermittent porphyria. Those are the two commonest, and then very, very rarely hereditary copper porphyria. And the French raised the issue, and then the Scandinavians in the last 2 decades have been on the forefront of actually showing quite definitively a link between the acute hepatic porphyrias, in their population at least, and HCC risk. There's a very good systematic review from last year looking at about 7,500 patients with acute hepatic porphyria, showing an HCC overall rate of about 3%. So there seems to be this link. It's in the screening guidelines for HCC, certainly in the European Porphyria Network, and it is something one should probably be doing. From our perspective, we've never really seen it, and that's why I was kind of interested in this patient, Mark, because if this is related to that, it may be the very first, patient who has potential porphyria associated HCC, although I am saying that she may have other potential risk factors as well. So it's an interesting academic question, but that is just the issue between the acute hepatic porphyrias and HCC risk. Thank you.
Okay. Thanks. So I think, yeah, so from our side, I think I agree. Like, we'll see what happens and see how she does. I mean, I don't think resection is off the cards.
Yeah.
But I think, now that we've controlled the bleeding, we see how she does over the next few months, and then re-image her and then take things from there. Yeah.
Great. Thanks, Mark. Should we go on to the
Yeah,
next
let
case?
me go on to the-
If there are no further questions.
Okay, I'll go into the next one. So the next patient is actually also known to Mark Sonrup. So this patient, let me just sort this out. Sorry, just want to show you so this patient was referred to us from a medical gastroenterologist. He is known to have metabolic associated fatty liver disease. And then he had spinal surgery in October last year, and had a pulmonary embolism after that and required anticoagulation, and then had a GIT bleed. And I'm not sure what they saw, but they didn't really find a cause for that GIT bleed. Then he had a scope done by a surgeon who lives out of Cape Town, and they saw this thing in the stomach, and they thought it was a polyp and referred it to a gastroenterologist for it to be snared, which luckily he didn't do. And he then saw this and sent me this video. We then elected to get a CT scan to see exactly what is going on with his portal venous anatomy. So he's had 2 life-threatening bleeds. He's got very good, well-preserved liver function, and he works in medical genomics and is very well informed about his health and his medical condition. So this is a portal venous CT scan, the axial views, and you can see the liver doesn't jump out being that abnormal, but what does jump out is the splenomegaly and these big venous collaterals. You can see it bulging into the stomach. You can see that there's a patent splenic vein and a patent portal vein. I'm just going to go on to the sorry, I just want to go to the coronals. The other thing that I think it's always important to look at, and we'll talk about that now, is is there a gastrosplenal shunt, sorry, gastrorenal shunt, which there often is in patients with gastric varices. So if you can make it out, I'm just trying to find the renal vein. There it is. You can see coming off the renal vein there, if I'm not mistaken. Yeah. So there is a gastrorenal varix that or collateral that's draining this whole area. So the question is now, the guy's not bleeding, what should we do? So I just wanted to review the management of gastric varices, because I think it's an area in portal hypertension where there's been quite a lot of advances in the last little while. So, you know, the management of esophageal varices is fairly straightforward, and there's a very good evidence base. When I say straightforward, you know, we start off with usually endoscopic band ligation, and the role of your salvage therapies and tips, I think, is quite clear. Gastric varices are less common than esophageal varices. They're supported by gastric mucosa, and they are less likely to bleed. But when they do bleed, they're associated with a higher mortality than bleeding esophageal varices. And the management I think is more complex because there's a greater variety of treatment options. And also, it's not always clear, certainly in the past, it hasn't always been clear when you've achieved your goal, because when you inject gastric varices, it's difficult to know if you've actually obliterated the varix, whereas with esophageal varices, you can see when they're eradicated. So I think that's been something that's been difficult with gastric varices. So like I said, the mainstay of treatment has been endoscopic sclerotherapy, and for the last probably 5 to 10 years, we've been using cyanoacrylate, and you can flush it with various things, and actually distilled water or 5% dextrose is actually a very good option. Endoscopic ultrasound guided treatment is something that's become available in the last 5 years or so, and we'll talk a little bit about that. And there's 2 options there. There's glue, once again, and coiling. And then there's 2 endovascular techniques. There's TIPS and there's BRTO. So this is a nice video that I got from an article that shows the EUSC guided management of varices, and I think why it's attractive. You can see the flow in the varix. You can see what you're doing basically, and it allows you to coil it. So you can see there the varix being punctured with a 19 gauge needle. It's better to use a Cook needle as opposed to the Boston needle, just because of the needle tip. And you can see here that there's a coil being deployed into the varix. So we had a patient I'll talk about it just now. So you can see there's the coil, and they're putting a second coil in, and then ultimately what is done at the end is they inject glue and use that to seal everything off. So you know, it's quite nice, attractive option. You can actually see what you've done. So your endovascular, your basic endoscopic techniques are just simple gluing. Then you got EUS management, and then you got your endovascular techniques. And I mentioned that there's TIPS and there's BRTO. So TIPS, this is a patient who had bleeding esophageal varices, and we basically you can see there's a Danner stent in situ, and you can see the TIPS stent going from the right hepatic vein to the right portal vein. And what we know is that it's very effective for controlling bleeding esophageal varices. But esophageal varices tend to only bleed once the hepatic venous pressure gradient is more than 12. Gastric varices bleed at lower pressures, and 15 to 50% of patients will bleed after successful TIPS placement. So it doesn't always work for gastric varices. And there's various reasons for it. One of them is that there are competing shunts, such as the gastrorenal shunt that a lot of patients have, that may maintain flow in gastric varices. That's not as much of an issue in esophageal varices. So so TIPS is not always a good option. It is sometimes a good option for gastric varices. Then you have BRTO, which stands for balloon occluded retrograde transvenous obliteration of varices. And basically, I think Gersh was going to talk to this, so I'm not going to go into much detail. You basically use that venous collateral to occlude the varices. But you are occluding quite a significant way that the portal venous system is decompressing itself. So it does result in an increase in portal pressure, generally in other parts of the portal venous circulation. It can worsen ascites, and it can make esophageal varices worse, which are generally quite easy to deal with. It's a really good option in certain patients, and especially patients who can't have a TIPS because of encephalopathy or cardiac issues. But the other thing that one needs to consider when you're dealing with gastric varices is the type of varices that you're dealing with. And I must say, I find every time I read these classifications, I find it very complicated, and I think you can make it simpler. But essentially, you get gastroesophageal varices type 1, which are very similar to esophageal varices. They're often associated with a large left gastric vein, the coronary vein, and they're continuous, and the gastric varices are along the lesser curvature. Gastric esophageal varices type 2 are along the greater curvature and the fundus. Then you get isolated gastric varices that are just in the fundus, and then you get isolated gastric varices elsewhere. So there's various classifications. I'm not going to go into it in too much detail, but I think this picture of the anatomy of gastric varices is quite useful. So you have your gastric varices, you have various vessels that can feed into it. So you can have a left gastric vein, that's sort of a right-sided structure when it comes to the stomach. Then you have your short gastric veins and the posterior gastric veins, which are on the left and come from the splenic vein. Okay, so TIPS tends to work better when you've got a large left gastric vein feeding the whole process. BRTO works better for these left-sided issues. If you look at and it sort of and there's an association with the different types of patterns of varices and which veins you have and which treatment option you need to do. But I think the point is you should get a good CT scan and then plan what you're going to do. So the patient that we had, it seemed to be more left-sided problem. I thought that BRTO would be a good option to try and do before we maybe go and have a look with a scope and see what's happened. So that's what we did this morning. So Gershwa got into that gastrorenal sort of shunt or whatever you want to call it, and there was a little tributary coming off that he coiled because you don't want to have any of the sclerosant agents going elsewhere. And then he coiled it just as it was coming into the renal vein, and you can see quite a lot of coils were used. It was a very large caliber collateral. At the end of that, I went down with the EUS scope, and there was still some flow in the varix. And this is just a picture of us injecting endoscopically glue directly into the varix with lipidol. So you could see the glue mixed with the lipidol. That's us injecting it. And the final result, you can see the darker glue was the glue that we injected endoscopically, and this collateral extending all the way down to the renal vein. So that's just some of the things some of the problems that you can have with gastric varices. So that's the end of my case. Wanga, so I think so my case, Wanga's also got a case on gastric varices. I wonder if we should maybe just show that straight away.
Let's do both,
and then we can take some questions.
And then we can take questions afterwards.
Okay. I'm going to stop sharing.
Yes, I'm just going to present a very quick case. It's a case of a 45-year-old female that we also saw here in Fortescue Hospital. Patient presented with upper GIT bleeding that was also life-threatening. Patient came in hypovolemic shock. At the point of presentation, it was one of the provincial hospitals. They had tried to resuscitate the patient given blood products, but unfortunately, the patient still went south and they proceeded to do a gastroscopy. At gastroscopy, they could see bleeding gastric varices at the cardia. I think this was in the middle of the night and they couldn't really inject those varices. A patient continued to bleed and the surgeon on call at that time opted to do a laparotomy and oversaw the varices. This seemed to have worked and the patient was later on transferred to us, and we did repeat the endoscopy in our unit, which did reveal the gastric varices. As a routine, we tend to do a CT scan just to investigate further the cause of the portal hypertension, also just to map up the anatomy as to so that we can plan further intervention. So otherwise, the patient on arrival to us was well with no overt signs of portal hypertension. We did the CT scan, which did reveal that the patient had features of portal hypertension and also portal vein thrombosis, which was investigated and no cause was found, and we labeled her as idiopathic portal vein thrombosis. So the scan that we did, which does display features of portal hypertension. You can see the spleen is sort of borderline or to splenomegaly. There is some venous collaterals around the spleen and also some cavernotomous transformation around the portal vein and also obliterated portal vein. And I'm just going to show a sort of a cross section. You can see the left gastric varices that decompress into the left renal vein, a similar case to what Dr. Benon presented. So for this case, we also proceeded to do a BRCA access through the left jugular vein, and we injected some coils. This was a success. There was no adverse complication from this. Patient has not continued to bleed in the ward post-intervention. So we're planning on following her up with further endoscopy to see if she's going to transform from gastric varices into esophageal varices, which Dr. Benon has already alluded that they're probably much easier to deal with than the gastric varices. So she's planned for endoscopy at a later stage.
Mark, if we just come to your patient, what would be the good strategy? Because looking at those nodular gastric varices, they look very threatening, and what one doesn't want to do is to intervene endoscopically and get uncontrolled bleeding. So the question is there a place for BRTO before or synchronous as you've been doing?
So that's what we did now, and that was the reason. When I saw that, I've had situations before where you now got a patient who's not bleeding, and you try and intervene, and you end up with a situation where you have uncontrolled bleeding. And so I was very worried that we were going to get into that situation. And Gershwin did a very good BRTO, but there was still some flow in the gastric varices. And I've had it before where we've done a BRTO and subsequently had some bleeding. So I think it is attracted to approach it from both sides. Yes. But I tried to do it with EUS guidance today when we did it, and I got quite significant bleeding, and then I lost access, and it was
that was despite
despite the BRTO. So then I came out, and we then injected the glue with contrast under screening, and that worked quite well. So I think we might have been in big trouble if we hadn't have done the BRTO first. Yes. Because there was bleeding, but the patient never became hemodynamically unstable, and it was fairly easy to deal with. So when I consented this patient, I said to them, there's a chance if we have uncontrolled bleeding, and then our bailout procedure would have been, if there was uncontrolled bleeding, I think would be a splenectomy and a devascularization. But that can be a very bloody, difficult operation. Yes.
Well, could you just mention the technical aspects of EUS guided injection? And you use a mixture of Lepidol and hysterectomy. Is it 50-50?
So Gershwa's the expert on this, and he's been educating me a lot in the last week or so, because we have we haven't. the thing was that Lipidol wasn't readily available, and it's become much more available. So it's a really nice thing to use, but there's a few interesting things about it. It's corrosive to plastic. So we don't have glass syringes anymore, but you can actually see it eating away at all the plastic stuff that you use. So you can use it. If you use glue neat, it polymerizes almost straight away. If you dilute it to like 1 in 5, which we did on that first injection, it sort of tracks further into the venous system before it polymerizes. And the other nice thing with the Lipidol is that you can actually see it on screening.
Yes.
So that I think that makes it very, very, very attractive. So we use a 19 gauge needle. So that's the bigger EUS needle, and the Boston needle is sort of designed to take biopsies, and it's not the best needle to use when you're trying to you want something that's really sharp when you get into the gastric varices, and that was the other problem. We didn't have that needle when we did it now. So a Cook needle is a really good needle to do, and get your angle right. And I think, I think the most experienced EUS person around should probably do it. And I think those are the tips that I can give. Yeah.
Let's ask you about the role of coiling and glue at the same time. Have you tried that?
Yeah, so we've done it twice. We didn't do it in this patient. The varices were so big, we didn't actually have big enough coils. So Gersha can speak a little bit about the sizing of the coils, but the varix diameter that we measured in the stomach was 17 millimeters. So you should use a coil that's bigger than that. And the biggest coil we had was 16 millimeters. So we thought that might embolize away. So I think a combination of coils and glue is quite nice. And the glue sort of sets around the coils.
Yeah. I think the important message is that one shouldn't be using histosacral neat, because the big worry, when it comes in contact with blood, it polymerizes almost immediately. Yeah. And the big danger is that your needle is going to be trapped within the gastric varix. So you're going to have to rip it out. So previously, when Lipidol was in short supply, we used propofol. Yeah. And it has the same effect, but it's got the disadvantage you can't see it on screening. Yeah. But if people haven't got Lipidol, you can use propofol in a 50-50 or a 60-40 combination.
And then another thing that I've learned is flushing it down with 5% dextrose actually works very well.
You've got to do that.
Yeah, it really works nicely. Yeah. So just a thing with Wanger's case. So when I first heard about Wanger's patients, in my mind, I was a little bit critical about what was done. But I think it's easy to be critical when you're sitting in a well-resourced environment. But when you're faced with a patient who's exsanguinating, it's they did save the patient's life. But I think the correct operation to have done probably would have been a splenectomy and a devascularization in that situation. Yeah. And we have been reluctant to go and scope that patient now because they've just had their stomach opened, and we thought BRTO was a nice, attractive way of dealing with it. But I think in about a few months' time, we should scope it and see what's going on.
I would just ask if Gershwa could just come in, and maybe you'll pick up on this with your discussion, but the role of BRTO when you've got some degree of portal vein thrombosis, is it a technical problem? Can you get there, Gershwa?
Hi, everyone. My understanding with BRTO patient with portal vein thrombosis is, so once you do the BRTO, that increases the pressures in the portal system. So you actually shunt blood into the liver. The scary thing is that if the outflow is impeded due to portal, like liver cirrhosis and hepatopetal flow, then there is the risk of you causing quite significant stasis from the SMV, splenic vein outflow, and then the hepatopetal flow from the portal vein. And that stagnasis can then worsen or contribute towards quite significant portal vein thrombosis and SMV thrombosis. Yeah. So one has to be sure, I think, that you don't sit with a patient with quite severe portal hypertension and already lingering significant portal vein thrombosis. the patient has very bad hepatopetal flow, then yes, that can really worsen it. But in a patient where the hepatopetal flow is not that bad, the extra blood and pressure that's now forced into the liver can actually help clear the portal vein thrombosis. So it isn't a clear-cut yes/no answer, unfortunately.
Thank you very much indeed. If there are no further questions, and I really encourage anybody to enter their questions on the chat box. Mark, let's have a look and see if there's a question there.
How do you take? So sorry, there's a question from Wisdom. How do you take out the EUS scope and the 19-gauge needle with the cyanoacrylate glue, which damages the scopes? So it's a very good question, and we have never glued a EUS scope closed yet, but we've only ever done this on 3 patients. And so when I've done it in the past, I've always injected the glue so I've gone down and looked with the EUS scope. If we've put coils in, we've used the EUS scope, and then when I've glued, I've taken out that scope and used the gastroscope, just to make sure we don't mess up the EUS scope. But the 2 previous patients we did in state, this patient that I did at UCT private, and I felt that that the private hospital can afford to replace the EUS scope if it was messed up. So I tried to inject the glue through that scope, and I was just very careful. Yeah. But I think there is always that risk, and it's potentially a problem. Yeah. So I think they talk about injecting the glue and then flushing, making sure you flush it through with the 5% dextrose, then withdrawing the needle into the sheath and waiting a little bit, and then withdrawing the needle out through the scope. I think that's what you're supposed to do.
You can, of course, leave the needle out and take out the scope rapidly once you've straightened it. But that's another way of doing it. If you're concerned about and you don't want to trap the needle within the channel. Okay, I see there are no further questions, so let's move on to your talk, Gershwa. Are you ready to go?
Okay. You should be seeing my presentation. Okay, awesome. Okay, hi everyone. I'm Gastroenal from radiology. I'll just touch on a few aspects of HCC and TACE, and then liquid embolics regarding liver disease. So we're just going to talk about that. So I think you guys know quite well that the treatment options in patients with HCC is quite multifactorial. A lot of things are taken into consideration. It ranges from liver transplant, resections, ablations, then TACE comes into play, and there's also systemic treatment. And I just referred to the Barcelona criteria. And then, as you can see, there are specific indications where TACE is indicated, but obviously it depends on area and multidisciplinary discussions of when exactly one would want to do TACE. I mean, even if they consider doing resections and transplants, then depending on socioeconomic things as well, I think that also sometimes urges you towards other options. So as Mark mentioned, there are a few options regarding TACE, so the transarterial chemoembolization. So once one considers doing that, I think a long time ago, they firstly started off with bland type of transarterial embolization, which is, and I'll show you now, is just basically particles one injects into the vessel supplying the tumor, cutting off the blood supply, and then doing so, hoping that will improve the outcome. However, treatment research has shown that didn't really contribute to the survival outcome of the patients. So following that, they started mixing the embolization with chemotherapy. So there are different types they use in different parts of the world. There's cisplatin, doxorubicin, that type of mixtures even are being used. In our setting, we use doxorubicin. And conventionally, like the CTACE is the acronym, is mixed with Lepidol. And then deptase is now the drug-eluting beads, which basically works like little dehydrated little balls. And as soon as they come into contact with the solution of the chemotherapy, they absorb it and swell up. So in theory, when they get released, or when one uses them as embolic material, and they sit and cut off the blood supply, they also get trapped in the tissue and sit and release the doxorubicin. But I'll quickly touch a bit deeper on that now. So just to go over again, so particles in a bland embolization, you can get what they call polyvinyl alcohol or microspheres, which are all at the same size, and then gel foam is also considered a particle. And then CTase is, like I said, Lepidol mixed with the chemotherapy, where Lepidol then acts as a type of embolic and gets trapped by the HCC. And then deptase is the beads that get soaked over time. And I can just show you some examples. So looking at the left of the screen, these are just our PVA type particles. And under the microscope, one can see that they are polygonal and not uniform in size. So they tend to aggregate, they tend to get, if they're too big, they can even get stuck in a catheter. And they usually tend to cause an inflammatory reaction in the blood vessels, and that leads to it embolizing and clotting off, apart from them just in itself block off the blood supply. On the right of the screen is more microspheres. They can be gel, acrylic type content or what they're made of. And in this picture, which is zoomed up, one can see that they are quite uniform in shape and quite, as opposed to the PVA. In that, they say it helps them to not get aggregated easily, so they can penetrate deeper, and your catheter doesn't get stuck as easily. And in the middle is the gel foam, which is not a permanent embolic. Usually after 2 to 4 weeks or so, it gets dissolved by the body, reabsorbed. And just as you can see, the different colors just denotes different sizes in micrometers. Different companies have different color schemes, so don't think that all the orange ones are the same size, or all the red ones are the same size. And then apologies. CTase, like I mentioned, is where your Lepidol, which is a product that comes from Europe and gets mixed with a 3-way tap action. You mix it with your doxorubicin, and doxorubicin, in our setting, doxorubicin is in orange, as opposed to cisplatinum or something which might be a different color. And this is how you make a water lipid solution, which you want to then infiltrate into the artery that supplies the tumor, or the tumor itself. Like I mentioned, the tumor has affinity for Lepidol, and Lepidol actually gets stuck into the tumor. So that's sort of how, which is the great thing of using CTase and the doxorubicin, so how it works, it gets stuck into the tumor, and then also it slowly releases the doxorubicin. Whilst with deptase, as I mentioned, it's this little spheres that's initially dehydrated, and as soon as they come into the solution, they swell up, and they definitively get trapped because they're not a liquid, so, and they're only a certain size, so they can't really get through the capillaries and the parenchyma unless there's a bit of AV shunting. But just for a diagrammatic representation, the top left is, for example, an HCC, and then going to the right, we've injected the beads, and as you can see, they sit more in the tissue and the small capillaries, and they will start releasing the blood, the chemotherapy drug. Lepidol is a bit more liquid, so it tends to flush through the tumor. Certain people will believe that even if you saturate it enough, that it would even be Lepidol that will fill up the portovenous channels that's supplying the tumor. And then and this will lead to necrosis, or that's the idea behind the chemotherapy embolization of HCC. And just another diagram. And these are some radiological representations of in a CT where one sees these hyperenhancing lesions. During the DSA, one can appreciate the tumor hyperenhancing in the top right-hand corner. And on the top left, there was also areas of enhancement. But as you can see, it's a lot more of a geographical region, which would probably need to be tackled by a larger section of a vessel supplying a larger segment of the liver. So in the top right of picture C, this is what they did. So they injected this one C lipidol, C tase with lipidol, and the tumor having affinity for the drug gets absorbed firstly before the normal liver does, and then similarly to the other lesion. And this is a post-tase CT scan, and one can see the bright areas is actually lipidol. So lipidol in itself is also a contrast medium, which is quite nice. And then F was just to follow up, and one can still see trapped lipidol within the tumor, and no arterial enhancement on the CT, denoting well embolized tumor. One would tend to ask what's the difference in outcome between C-tase and DEP-tase, and there's actually quite a few studies which has not really been able to show significant difference between the two in overall survival. The one thing people tend to notice is that there is a smaller amount of side effects in patients that uses DEP-tase. Since it's not a liquid and it gets trapped, you don't get any of those side effects from chemotherapy that gets released systemically. So doxorubicin tends to give hair loss, a lot of nausea and vomiting, and they see that a lot less with DEP-tase than C-tase, although in both instances it's not a lot. The side effects is not really that evident. So just to go on to the next part of the talk, just talking about liquid embolics and then in liver disease situations. These are just 4 types of liquid embolics that we get. So liquid, like literally, liquid that one injects, and the fear is that it will just basically rush off and can go anywhere since it's a liquid. And so that can be anything from ethanol, lipidol, histoacryl glue brand, which is then glue, or Onyx is another type of fancy liquid embolic, which doesn't adhere to anything, but it just occludes and fills up the space. So especially in portal vein embolization, liquid embolics are now showing quite significant results following the embolization. As you might know, portal vein embolization would be to promote growth of the contralateral side, so either the left or the right side, depending on which side one would like to remove. And in doing the embolization, one would like to increase your functional liver remnant to make sure your patient will survive afterwards. So in the patients who have received liquid embolics, they've seen increases from 30 to 60% in within liquid embolics, closer to the higher end in comparison with the more particle-based embolizations. The big complication with portal vein embolization in itself is actually contralateral embolization and liver abscesses, and even more so with contralateral embolization using liquids, as it is quite fluidy and can be sometimes a bit unpredictable. And then I didn't touch on this in this talk, but particles, oils, and plugs can also be used to embolize. So this is an example of a patient where they've used ethanol as an embolizing material. Images just shows them starting off with a portogram. They used a balloon to occlude the main right portal vein, and then injected subsequently ethanol. Kept it in there for a few minutes, and then as they came out, they just did a run post-embolization, and one can appreciate that there's no filling of the right portal vein afterwards. So this was a case of ethanol. There's been, like I mentioned, risks of abscess formation, and then also, which is not uncommon, and then one just has to be careful that it doesn't spill over to the other side. This is an example of patients where they used Onyx. So Onyx, like I mentioned, is quite a special type. It's not like glue. Your catheter doesn't get stuck as easily, or that it can get stuck. They might say that it will never get stuck, but that's not true. And then one just has to make sure that they use a specific catheter that's compatible with DMSO, which is basically the 5% glucose for Onyx. So that will make sure that it doesn't get stuck in your catheter. So you flush your catheter firstly with DMSO, and then you'll inject the Onyx. And Onyx is quite nice that you can really control how it comes out. You can see it also under it's radio opaque, and you can really, it really looks like slow flowing lava, almost filling up the vessels. And again, looks very similar. So they did a portogram first, and then they used their catheter firstly in the right side, on the posterior segment, filling it up with Onyx, and then filled up the anterior segment, very nicely done afterwards. And then the post run, actually you can see the areas where there's no contrast filling. So the right side was completely embolized following the Onyx embolization. And then something that's more readily available probably is glue, since it is not as expensive as something like Onyx. And like we mentioned earlier, it's mixed with Lepidol just to give you a bit of a more of a diluted, a dilution that can flow more distally. Again, you prime and flush your catheter with dextrose, and it is recommended to rather use a coaxial type system. So you'll have a catheter in and then have a microcatheter through that. And just in case you need to, like bail out, you can always pull out the microcatheter and you're still there with your normal catheter. And it tends to polymerize in contact with ionic solution, so like blood, and they say don't flush with saline. So yeah, use dextrose if you want to flush it. And it will just prevent it from polymerizing. So very similar in appearance. Portogram was formed, and they went in with their microcatheter coaxially through another catheter, and they filled it up with glue. And the middle picture in E shows the post-run, where you can see the left side filling, but nothing on the right. Just see the shadow of glue casts. And then as they came out, they glued the tract as well. And then lastly, just talking about the varices, as we already mentioned, so I won't go too much in detail, but yeah, something that was interesting for me is that it has a low pressure system. It's coming off a low pressure system, so it's one of the, not as a high pressure bleeding, and the mortality rate can be quite high. And then, the patients will present. And then, yeah, as Mark mentioned, they often, it's from a left-sided, it's often with the left-sided origin. Say a patient has splenic vein thrombosis or something like that, then one can often find isolated gastric varices. And then a BRTO is the original name. So it's basically balloon-occluded retrograde transvenous obliteration. And they've now moved on to changing it up with either using a plug or a coil. And there's even instances where they go antigrade, not just retrograde. But I focused on the retrograde. And then, as Mark mentioned, you can get afferent inflow into the gastric varices from left gastric or these posterior gastric veins or even small gastrics. And then it tends to have outflow through either normally the gastrorenal shunt. That's a very common one. You can also decompress via the gastrocaval, or even into the inferior phrenic areas. So when doing this procedure, the saying is that if the efferent outflows is quite a fast or a big one, it helps to embolize that. So as we did with the patient from today, just to minimize losing your embolic or sclerosant in the varix. And then, as mentioned, one would go in with a balloon. That's the old way or the original way described, injecting a sclerosing agent, keeping the balloon in there for anything from at least 4 hours to 24 hours. So patients used to go to a high care and just has to lie there. And then one can deflate the balloon. It was quite tedious. So they came up with these coil-assisted techniques where they would go in with the balloon, inject the sclerosant, and then coil just before they come out, and then come out with the balloon. And then the coil will help the sclerosant to stay there and continue having effect onto the varix to sclerose it up. So this is just a true version of where they went in, coiled, and then had a microcatheter distally and injected the sclerosant. And then this is an example of a plug-assisted one. So you deploy the plug and then you inject distally. And then things you can use is either what they call a sotradecol or sodium tetradecol sulfate. It's very much like a jig, if you want to put it that way. You mix it with air and lepidol in a certain ratio, just to increase its surface area. So, and this definitely needs some hours in contact with the vessel to start sclerosing it down. So that's what one would want to plug it quite thoroughly, not to lose any of that sclerosant whilst it's in there. The other one that they use, especially in Asia, is ethanolamine. It causes hemolysis of the red blood cells, and to prevent any adverse effects when they would have the patients on haptoglobin infusion during the procedure and afterwards, as the breakdown of the hemolysis can cause renal disturbances, even lead to renal failure. So, and then the other technique is using a gel foam slurry. So that's where you use gel foam, you mix it up, and then you can inject it, and you sit there and clot off the varix. And then one can understand that it's not like the jig that needs time to sit there. This will just definitely stop the flow and cause coagulation. So slightly different. This is just images showing one would draw up the sotradecol, mix it with air, and it will really become like a foam that you just fill up the varix with. And then this was a similar case, as you saw, something I got from an article where they went in and plugged it and injected the sclerosing agent to sit there afterwards. Yeah, thanks very much.
Thank you very much, Gashua, for a very comprehensive overview. I just want to ask you a question. When you're doing the TAE, the bland embolization, what are the criteria that make you choose the various elements that you inject, either glue or the microspheres? Is it the size of the vessel or the tumor?
That's a good question. So definitely the size of the vessel, the flow actually. So once one is in there with your catheter and you check it, you do just a little run with contrast, and you see, like how's it pushing back, how's the flow going forward. That sort of, definitely makes me wonder or think about what one can use. Glue is something that's nice to use, especially if if it looks like it's difficult to embolize just with particles, say, if you're worried about the outflow being quite rapid or something. They say that you can make like a thick concentration of glue that's quite goopy or gloopy, and that will just fill up the spaces necessary and just sit there. So that's quite nice. But choosing something like, if you want just things about particles is quite nice, and also quite cheap in comparison. PVA is a nice one to use, as it's cheaper than microspheres or those fancy round ones. So yeah, that's sort of, I think, more in a trauma situation, where you need something readily on hand, then PVA works very nice, especially like a bleeding case like we had with the ruptured HCC.
Great. Thank you very much indeed. I see that there aren't any further questions in the chat box. So we are at 65 minutes. So I think we'll conclude the meeting. I think you'll all agree it's been an excellent presentation from all three speakers. So thank you, Mark, Gershwa, and Wonga. Thank you very much indeed for your participation. Thank you also to the sponsors, and thank you to the GI Foundation of South Africa for hosting the GECKO meeting. And as well, thank you to ECHO Mexico, New Mexico, and to the India team. Thank you very much. And this concludes today's meeting. Thank you and bye-bye.
Jake, thanks, Mark. Nice to see you.
Thank you.
Thanks.